Good morning. I am an assistant of Department of Traumatology and Orthopedics, J.A.Rizayev. Today's topic is lower limb fractures and dislocations. Mechanism of fractures. Lower limb fracture is the result of a high energy trauma except in elderly people or diseased bones. Types of fracture are dependent on position of limb during impacting and magnitude of force applied. Management. The proper way to treat a patient with high energy trauma is to look at the patient as whole, not to injured limb alone. So the aim to treat such patient is to save life first, then save limb, finally to save function. Pelvic fractures. Pelvic fractures is a high energy trauma as a result of car accident, fall. Classification. Type A, stable, fractures of the pelvic not involving the ring. Second, stable, minimally displaced fracture of the ring. Type A, stable avulsion fracture. Type B, open block. Type C, unstoppable vertical fracture. Type B, rotationally unstable, vertically stable. Open block, lateral compression, contralateral. Type C, rotationally and vertically unstable. Unilateral, bilateral, associated with acetabular fracture. Management, aggressive treatment, obtain X-ray, pelvic, inlet, outlet, CT scan. Emergency treatment, protect primary blood clot by early pelvic springage and prevention of excessive movement, fluids, early blood transfusion, early fresh frozen plasma, platelets, cryoprecipitate, prevent hypothermia and acidosis, stop other bleeding sites, stabilize pelvis. Complications, hemorrhage, life-threatening, bladder, bowel injuries, neurological damage, obstetrical difficulties, persistent sacroiliac joint pain, post-traumatic arthritis of the hip with acetabular fractures. Acetabular fractures, usually it is a result of high energy trauma. The acetabulum is divided into 4 segments, an anterior column and wall, and the posterior column and wall. Fractures of the acetabulum are classified based on their involvement of their structures. Investigation, upper pelvis, Judat views, internal oblique, obturator views, CT scan. Treatment, indications for non-operative treatment. First of all, non-displaced and minimally displaced fractures. The second one, fractures with significant displacement, but in which the region of the joint involved is judged to be unimportant prognostically. Third one, secondary contiguous in displaced both column fractures. Operative treatment, indications for operative treatment. First of all, an acetabular fracture with 2 millimeter or more displacement in the dome of the acetabulum. The second one, any subluxation of the femoral head from a displaced acetabular fracture noted on any of the 3 standard Röntgen graphic views. Bilateral acetabular fractures, right side with severe displacement. Complications, post-traumatic arthritis in 70%. Vascular necrosis after posterior dislocation was 7.5%. Infections are reported to occur in 1% to 5%. Sciatic nerve pulses as a result of the initial injury occur in approximately 10 to 15%. Heterotropic ossification occurs after most extensive approach. Hip dislocations, anterior, blow to knee hip widely abducted, clinically limb fixed, extremely rotated and abducted, attempt closed reduction and then kete of hip to assess joint congruity. Posterior severe forces of knee, hip, flexed and adducted. Clinically limb shortened, intimally rotated and adducted. Sciatic nerve injury common. Mechanism of anterior dislocation. Extreme abduction with external rotation of hip. Anterior hip capsule is torn or avulsed. Femoral head is levered out anteriorly. Physical examination, classical appearance. Posterior dislocation, hip flexed, internal rotated, adducted. The typical position of posterior dislocation of the hip. The Whistler maneuver. Complication, post-traumatic arthritis, femoral head injury with risk of AVN, 100% if the dislocation lasts. Sciatic nerve palsy, 25%. Femoral shaft, neck fracture, knee injury. Treatment, neck of femur. Non-displaced fracture of neck of femur can be treated with cannulated screws. Displaced fracture if in patient less than 60 years. Then 65 years, look for level of activities, status of the acetabulum, then choose hemiarthroplasty. Metal osteosynthesis. Supracondylar femoral fracture, high energy, multiple trauma. Knee joint is disrupted severely with bicondylar fracture. Poor prognosis with comminuted fractures. High incidence of post-traumatic arthritis. Treatment, internal fixation and early knee ROM. Quadriceps strengthening. Non-operative treatment, long leg cylinder cast for 4-6 weeks. May consider a knee immobilizer for the elderly. Immediate weight bearing as tolerated. Rehabilitation includes range of motion exercises with gradual quadriceps strengthening. Operative treatment goals: preserve extensor function, restore articular congruency. Preoperative setup: tourniquet prior to inflation, gently flex the knee. Approach: longitudinal midline incision recommended, transverse approach alternative, consider figure surgeries. Operative technique: modified tension band wiring, leg screw fixation, cannulated leg screw with tension band, partial patellectomy, and patellectomy. Patella fractures. Dislocated knee, bad high energy injury, associated injuries, investigations, angiogram and treatment, closed reduction above knee cylinder cast 4 weeks. Alternative, external fixation, especially if vascular repair, surgical repair of all ligaments if high dement patient. Distal tibia fractures, pilon fractures, tibial plafond fractures due to axial loading forces following the RTA or fall from height. Males are more commonly affected than females. Mean age is 35 to 40 years. Classification: type 1, undisplaced cleavage fracture of the joint and are usually low energy injuries in which the fracture fragments are nearly aligned. Type 2, displaced but minimally comminuted fractures and are usually moderate energy injuries. Type 3, highly comminuted and displaced fractures and are usually high energy injuries. Clinical features: pain, swelling, deformity, inability to bear weight, loss of sensation. Treatment: minimally displaced fractures treated with a plaster cast on external fixator. Displaced fractures, open reduction and internal fixation with plate and screws. Complications include infection, malunion or union of the fracture in an unacceptable position, non-union, that is failure of the fracture to unite, arthritis of the ankle joint. Thank you very much.